So I am delighted, beyond delighted, to introduce Dr. Theresa Rowe, who used to be my geriatric fellow years ago, and was on faculty here at Northwestern and is now still adjunct faculty with Northwestern Geriatrics. But she has gone on to really amazing things, and she is the medical officer, long-term care unit team lead in the surveillance branch for the CDC. So she's a fancy director at the CDC, or big boss lady, as I like to call her. And she will be talking about RSV disease in older adults. What many people might not realize is that she's double boarded in geriatrics and infectious disease. And she has spent a lot of time working in skilled nursing facilities and long-term care setting. So please send her happy thoughts, and I'm so excited to introduce her. So welcome, Dr. Rowe.
Well, thank you so much, Dr. Lindquist. And thank you all for the opportunity to be back here at Northwestern, even if it's virtually. And as Dr. Lindquist just mentioned, I'll provide a little bit of background about myself as well. Yes, I was very fortunate to have trained here underneath Dr. McCoy, who I don't know if is here, but was my fellowship director and was amazing. And Dr. Lindquist, who I owe both of them just so very much. About a year ago, I joined the CDC as the long-term care unit lead for infection surveillance in nursing homes. And, we've actually recently begun, as you'll hear in this presentation, looking at RSV in nursing homes or respiratory syncytial virus or RSV in nursing homes, which really brings us to the topic for today's presentation, which is respiratory syncytial virus or RSV in older adults. The burden of RSV in older adults has been a really hot topic of interest over the past couple years for several reasons, as we'll get into very shortly. Okay. I have no disclosures, and I want to highlight that this presentation does not reflect the position of the CDC. It's mine.
I'm going down.
Okay. Okay. So as I mentioned a moment ago, RSV has really gotten a lot of attention over the past 2 years, primarily for two reasons. So first, with the increased use of viral PCR testing, or all those multiplex testing that we've been doing in the emergency rooms and in nursing homes, we've really been able to better understand the burden of RSV. And then secondly, as most of you are probably aware of, the newly approved RSV vaccine in adults age 60 years and older. And so with that, I'd like to first discuss the objectives today. And there, we'll talk about, first the burden of RSV disease in older adults and sort of the epidemiology of the disease. Briefly discuss risk factors in clinical presentation. Then we'll move on to RSV testing and prevention, and really focus primarily on vaccination. And then I'd love to just to give a little bit of shout out to some of the work that I've been doing and looking at surveillance of infections, but we'll talk about RSV here in nursing home residents. Okay, so I know we're not virologists, but I wanted to provide a visual of the RSV structure and targets for vaccination. So RSV is a negative sense single-stranded enveloped RNA virus. It has F and G glycoproteins, which I highlighted in the blue box there. And those are the two major surface proteins that control viral attachment in the initial stages of infection. The G protein over here is the primary mediator of attachment, and it's highly variable, so it changes. And that's the one that actually binds to the receptors on epithelial and immune cells. And then after attachment, you have this F protein up here, which undergoes structural changes into a post-fusion form, highlighted in this box here, that forms the initial viral penetration by fusing viral and host cell membranes. And that F protein is relatively conserved between subtypes, and that's the main target of all the new vaccines that are coming out that we'll go over. It's that F protein. Okay. So RSV follows a pattern of other respiratory viruses. You can see here it begins generally in September to October and ends in May and peaks generally around late December and mid-February. So it kind of looks like, flu or human metapneumovirus or any kind of cold that we typically see. However, I do want to point out that particularly with RSV, human activity can impact the seasonality of it and the peak of RSV. And RSV activities actually can vary pretty significantly by region, which is a little less common with the other viral illnesses. And so, for example, as I'm going to show you in the next slide, during the SARS-CoV-2 pandemic, RSV actually did not follow seasonal trends at all. And this actually becomes really important when we start talking about RSV vaccinations, because the RSV seasons were very altered during the pandemic and in the few years after, when a lot of these vaccine studies were going on. So here's data. It's from the CDC that's called RSV Net, and it looks at rates of RSV-associated hospitalizations over the past, and you can adjust it however you want. And I looked at this age group of 65 years and older over the past several years. And just wanted to highlight a few things here. So here's the blue, this blue line down here was actually the pandemic year. And as you can see from the blue line, RSV did not follow a seasonal pattern during the pandemic, and levels of both cases, not shown here, but also hospitalizations, were very low. And this was likely due to kind of what we saw with other viruses, that there was a lot of social mitigation and other competing infections such as COVID-19. And then after the pandemic here, for 2021 and 2022, I have those highlighted in the green lines here. You can see that there was actually a kind of a peak here in like the summer of 2021, and then a severe peak in 2022, actually much higher than these other seasons before. I think these are like 2016 to 19. So definitely just a different, not typical RSV season over the past 3 years or since the pandemic. I adapted this slide from a presentation that Dr. Angela Branchi at Rochester gave, and I really like it because it kind of not just tells us a little bit about RSV, but also compares it to influenza. And I think we generally hear influenza as impacting older adults, and we think RSV impacts younger kids or babies and infants. And I think here you'll really see how actually RSV in older adults is a pretty significant cause of morbidity and mortality in older patients. And actually really compares in many ways to influenza. And so approximately 160,000 to 180,000 hospitalizations per year in adults age 65 and older. Around 13,000 deaths. I saw a couple of studies that had higher per year. So, really actually very comparable to influenza. Even though we tend to think of RSV, or a lot of people tend to think of RSV as a pediatric, as causing significant morbidity and mortality in those, younger pediatric populations. Okay. This study is from, I think, 2020, and it was a study that looked at around 664 patients who were hospitalized with a confirmed RSV, age 60 years and older. And most of them, I think, were actually in the even older cohort, so 75 years and older. And I just put a couple of highlights from here. In this study of hospitalized older adults with RSV, almost 3/4 of the patients, I think it was 80, had developed pneumonia, and most of them were radiographically confirmed. 66 and 80% were radiographically confirmed. 21% of those who were admitted required ventilator support, and 18% were admitted to the ICU. I know there's a little discrepancy there. I'm not so sure what happened to those patients, where they went. And the survival curve over here just sort of highlights the difference between the old and the older adults, which is not unexpected. But there was a significant trend towards increased mortality and that over age 75 group. I think overall mortality during hospitalization was about 6%, so pretty high. And as you can see on this survival analysis, morbidity was significantly higher in those age 75. And then at the end of the period, I think within 12 months, cumulative mortality was over 25%. Okay. I really liked, I found this in a study from 2007, or a review from 2017. And I just like it because it kind of shows like RSV across the lifespan. And as we mentioned earlier, we hear so much about RSV in younger children, usually younger than 2 years old, and manifests generally as RSV bronchiolitis. I'm sure all of us who have kids or nieces or nephews or around kids at all have heard about this. And then, there's some transfer maternal antibody, but relatively, you don't have a ton of immunity. Up here in this yellow is the typical clinical manifestations, and down here in blue is sort of immunity. And then as we move into adulthood, it mainly affects those with asthma and COPD and kind of that middle age group. So you might get a CHF exacerbation or COPD exacerbation. And then, as we get older, it can often present as this sort of insidious respiratory disease just at the time when our immunity levels are declining. And I think that's why we really see that really uptick in morbidity and mortality in this age group. Okay. So how do we tell the difference between RSV and the other two most studied or most common viral illnesses that impact older adults? And it's really hard, right? So you can kind of just take a brief look at, all the signs and symptoms here and see that they overlap quite a bit. I bolded I think I just got all these signs and symptoms from the different CDC web pages where they just kind of link, here are the signs and symptoms. So, in RSV, maybe more common, have a little bit of wheezing, influenza and COVID, very similar with chills. They also mentioned, more of a muscle ache, body ache, vomiting, diarrhea, and change in loss of taste and smell. But very hard to really distinguish. They all overlap. And I think we all know in our population, it's, it's usually, hard to further describe it than things like, fatigue and not feeling well, et cetera, et cetera. So hard to tell strictly by clinical, which virus somebody might have by clinical signs and symptoms alone. I guess just clinical symptoms alone. But there are, I think, several advantages to testing for RSV. In the past, it was thought not to be very beneficial to test for RSV in the older adult population because really there isn't much you can do about it from a medication or treatment standpoint. And the treatment is largely supportive care. However, I would argue that there are significant benefits, particularly in patients such as nursing home residents. And, first, it can really help you avoid unnecessary diagnostic testing, such as, maybe chest x-rays, other lab testing to determine the etiology of one's signs and symptoms. And so, if you have a positive RSV test and signs and symptoms that match, you can kind of leave it there. It can also help avoid unnecessary treatment, such as antibiotics that are not going to be beneficial in somebody with a viral illness or a viral etiology, and might help avoid that prescription for levofloxacin, or you might be able to stop an antibiotic that had been started, and you get the viral test, it comes back, it's negative, you can say you don't have to take your antibiotic anymore. Viral testing can also, as I just kind of alluded to earlier, help differentiate from other viruses such as influenza and COVID, which do have effective treatments. And here's just because I don't like pictures of viruses for this presentation, but it's just a visual of RSV and SARS-CoV-2 or COVID and influenza. And again, being able to distinguish from RSV from COVID and influenza has some benefit, because if it's influenza, there's treatment, but there's also prophylaxis. So that's really critical in nursing home residents, right? If you can identify a case of influenza early, you can prophylax those that may have been exposed and hopefully prevent a larger outbreak. With COVID, there is some treatment. And then with RSV, there is again, no clear treatment other than, symptomatic or, supportive care. But just another reason to kind of help, distinguish between these three viruses, especially in, congregate settings like nursing homes. Here's an older study. It's from 2019, so it's before COVID, that used a nurse-led testing model for the identification of viral illnesses. This wasn't specific to RSV in nursing homes, but it essentially RNs were asked to obtain a PCR to check for multiple viral pathogens in residents with signs and symptoms of respiratory infections. As expected, the number of PCR tests went up by about 50%. And as you can see from this table, I know it's a little small, that 50% of so in residents with RTI symptoms had a virus identified by PCR about 50% of the time. And they found that this led to 6 outbreaks being identified early, which led to appropriate infection prevention and control guidance, initiation and guidance to be enacted, and treatment for things like influenza to be started. So again, it just kind of, I think, highlights, why it is sometimes beneficial in certain situations to really understand the etiology of a potential circulating virus. Okay, so why don't we do it more? I think, this is probably self-explanatory. PCRs are expensive. I believe that they are getting cheaper, and certainly over the past 3 years since the pandemic, I know, and I'd love to hear thoughts later, they've been used a lot more. Unfortunately, the sensitivity for antigen testing is very low in the older adult population. The viral load is much lower than in children. And so in children's, you can sometimes get away with doing antigen testing. And I think that is still done, but just because of the differences in viral load.
You're done.
Okay.
You're done.
So also as I mentioned earlier, lack of treatment. So there's no additional supportive, or other than supportive care. We don't have any targets that or anything that targets those viruses specifically. And then specimen collection. You have to actually collect the specimen and do a nasal swab. Okay. So now that we've discussed the RSV burden, signs and symptoms, and testing, I discussed RSV burden, signs and symptoms, and testing. Let's talk about vaccination. So I'm sure, as everyone here is aware, that RS vaccine is here. Okay. So there are 2 vaccines that were approved by the FDA in May of 2023, and in June, the Advisory Committee on Immunization Practices recently recommended both vaccines, meaning, you could either use either version in adults aged 60 years old and older. However, as we'll discuss in the next few slides, this was not a blanket decision of everyone over the age of 60 should get the RSV vaccine. So for example, for flu and COVID, the recommendation is that everybody should get it. This was a little more tepid and or lukewarm recommendation, and the meaning of shared decision-making. And so they recommended shared decision-making. And the meaning of that is, obviously, I think everyone here probably knows like what it sounds like. A provider and a patient must jointly decide if it's the best decision for them. And so over the next few slides, we'll discuss the reasons for this sort of slightly softer recommendation in older adults. Okay. So we'll first go over the 2 studies that helped.
One real quick thing, Dr. Rowe, we're seeing all of the slides, including your conversation. So you might want to just switch over to screen only.
Like all of my slides, like
yes. We're seeing the notes you're reading.
Oh, okay. I thought it was like my other stuff that's up too. All right. Well. Let me try this again. 3rd time's a charm, right? Share screen. There. I'll just do the regular one from the beginning here. I guess from current slide. Does that work or no?
It's fine. I can still see everything on the next slide and so forth. I think you need slideshow. Is that one of the options?
Wonder why it's not working.
If you click the those three buttons on the bottom, you should be able to hide presenter mode.
Is there a way to like click off of it? I don't know why it worked from the beginning though, right?
Yeah, try clicking that button.
Did that work?
And if you click those three dots on your screen under your presentation, you should be able to on the.
Oh, I see. Yep. Okay, got it. Oh, yep, I got it. What do I do?
And it's going to
Hide view?
presenter view.
Okay, there you go. Did that work?
Not as it should. I'm sorry.
I believe if you hit the little icon above the word design, that should put you in presenter mode.
Oh my God, I'm so sorry, everyone.
Oh no,
Right about design.
these happen. Don't stress, none. It's
No.
a happy group.
Here,
Oh.
design.
Did you hit the icon above that?
Just trying to think. Should I just?
Resume.
I just wanted to go regular slide. I feel like something happened too during that because like I got this have this black screen on my screen now from those people.
Oh,
I
so
don't
you
know
know what?
if
Why don't you just exit out and I can share your slides from my screen? How's that sound?
Okay, do you want to? Let's do that.
Yep. So
So I'm
just
gonna stop sharing. Okay.
yeah.
Especially now, given some of the time. But the primary objective was the prevention of RSV lower respiratory tract disease during season 1. And if you look over here on the definitions, the primary outcome, there was really 2 definitions for the primary outcome. So one was at least 1 respiratory symptom and 1 sign, or greater or equal to 3 lower respiratory symptoms. They also included things like severe severe disease, acute respiratory infection, and obviously tested for the safety, immunogenicity, and reactogenicity of the vaccine. Okay, we can go to the next one. Thank you. So here are the results. So again, these were all PCR confirmed infections. There are almost 25,000 participants with a mean age of 7 years old and a mean follow-up of 7 months. So the first row here is looking at the events in the vaccine efficacy in adults age 6 year older who had who met the primary criteria. So it was 7 out of 12,000 over 466. This is the incident rate in events per 1,000 patient years, events in placebo, and then the incident rate per placebo. And you can see here that there was actually pretty high vaccine efficacy, even though the numbers were a little on the lower side at 82.6%. So they considered this, pretty effective. We can go to the next slide. I wanted to break it down just a little bit more because they did look at it in different age groups. And you can see in the first two rows here, this is the 60 to 69 and the 70 to 79 age group, still, documented that it was pretty highly effective. And then the third row goes into over 70, which again still shows, pretty good efficacy or effectiveness, and over 80, it starts to drop off. They really didn't have very many older adults over the age of 80. And this is a criticism that we'll talk about momentarily, though I will highlight that a lot of studies don't have, adults over the age of 80. So that was kind of a big limitation that they met, that they discussed. And the efficacy went down to, 33.8% here. We can go to the next one. So as I just mentioned, their conclusion really was that it showed high efficacy against RSV-related lower respiratory tract disease, again, according to that definition of a positive PCR test with 3, signs or symptoms, or 3 symptoms, and had an acceptable safety profile in adults aged 60 years of age. They did highlight a small number of frail participants, and I didn't go into detail here, but this is actually interesting to look at too, because they really had very few, most of the patients in this group are pretty healthy. Small number of adults over the age of 80, as I just mentioned, and they highlighted that they had limited ability to detect rare side effects. Okay. So we can go to the next one. Oh, maybe one back. Yeah. I don't know why I'm not seeing it on your end. That's okay. Let me just talk through this one and then, yeah, I don't know why that one's up there. Okay, so the second study was the Pfizer vaccine. You can leave it here and I'll just talk through it. The Pfizer vaccine was, again, a phase 3 multinational study, randomized, placebo-controlled. This was over 2 consecutive RSV seasons. Same thing, patient characteristics were over 60 years old. They had to have stable chronic medical conditions. And here they did a weekly electronic diaries and then reached out when somebody developed signs or symptoms and they had were tested. The primary objective here was prevention of RSV, lower respiratory tract disease with 2 symptoms, so LRTD. And if you look over at the definitions, they actually included 2, sorry. So one was greater than 2 lower respiratory signs and symptoms, or greater than 3 lower respiratory signs and symptoms. So they kind of had a more strict definition and I guess a softer definition. They also look at secondary characteristics, including things like severe disease, which I won't go into too much, but here are the definitions for that. Okay. And, I think they also found pretty similar results to, to the first study. There was about 35,284 participants. Mean age was 67 years old. Mean follow-up was about 7 months. You can see here, though, they did use the definition when talking about the sort of efficacy of the more stringent definition of 3 signs or symptoms in which there were, less events. But this is sort of what they highlighted as the vaccine efficacy of 85.7. So those with the more stringent definition of LRTD. Just wanted to point that out. So in adults aged over 60, RSV vaccine, this was their conclusion, prevented RSV-associated symptomatic lower respiratory tract illness. There were no apparent safety concerns. They did exclude immunocompromised patient. And given the sample size, they said additional safety data were needed and more analysis on the duration. And so this is just a summary of kind of what the main, what's sort of being reported out there for the GlaxoSmithKline vaccine for V greater than 3 LRTD. Vaccine efficacy was 82.6, and for the Pfizer vaccine, it was 85.9. I want to talk just a little bit about the safety profile because this is really, I think, where some of the more lukewarm or softer recommendations, at least, came from. So both studies reported an acceptable safety profile, but there was some concern for a couple severe neuroinflammatory events, as you all might have heard in the news. So there were a total of 6 neuroinflammatory events within 42 days of vaccination. In the GlaxoSmithKline vaccine, there was 1 confirmed GBS and 2 cases of adult disseminated encephalomyelitis, which is a much more severe, takes a much more severe course. And in this group sorry, I can't see me highlighting it, but in this group here, underneath the GlaxoSmithKline acute disseminated encephalomyelitis, or ADEM, the 2 patients who participants that got the vaccine the vaccine was co-administered with the flu vaccine. And so they highlighted it that, it was 2 events out of 15,000 people, or the population of the study. But there was, some people wanted, I think some people had brought out that, well, really, there was only 442 participants that got the RSV and influenza vaccine co-administered. And so wanted to just kind of highlight that, out of the folks that got both together, both of them had the ADEM, and so that was a 2. The denominator was a lot smaller, obviously, at 442. So I think, yeah, that's it there. Okay. Other thing I wanted to highlight that wasn't significant, but there were more events for both of the GSK and Pfizer. For atrial fibrillation. So this was unprovoked AFib found at less than 30 days. So you can see 10 events in both vaccines and 4 events in the placebo. Okay. So just other considerations after kind of going through these studies. there was, low long-term care enrollment. So 309 long-term care residents enrolled. So, very, very, very small proportion. Again, that's, a limitation, but not as that unusual, as we know that nursing home residents are unrepresented in all studies, have also been before in other vaccine studies, but certainly a limitation, particularly because this is being, could have benefited so much to our nursing home residents. There were few residents over the age of 80. Again, that's not that uncommon for many of these studies. Few frail. It was a very atypical RSV season. So when these trials were done, it was, right after the pandemic where we started to see kind of those atypical rates of RSV. So it wasn't sort of a more normal or what we would have expected to be an RSV season. There were definitely concerns about the adverse events. And as I just highlighted, I think the severe ADEM courses and, or the 2 severe ADEM cases, one of those who actually did die, and the fact that they were co-administered with the influenza vaccine. And another thing I didn't bring up a ton about were questions about duration of protection. And so there was not a great conclusion on how long the RS vaccine would be, how long you could, the duration of protection would be. I think they, said 2 years, but I think there were some concerns about that as well. Okay. So can we give flu, COVID, and RSV vaccines together? I think this is a question that everyone gets a lot. And so I would first say that there was not any data on giving the RSV vaccine with COVID. So we don't really know there. It kind of depends on who you ask. So at the bottom here is the Canadian recommendations, and they actually say that the RSV vaccine not be routinely co-administered with COVID and flu, but to use best judgment. So certainly if, there's an outbreak or community activity, or there's a significant risk of a patient not receiving because they came to the doctor, they're not going to come back, then you can give it. But if there's, if it's feasible to give it, 2 weeks later, then that's what they would recommend, a 2-week interval. The ACIP and CDC recommendations say that it's acceptable to co-administer RSV vaccine with influenza vaccine. And again, we don't know any data with COVID. And we don't really have to go through this, I know, because now of all the issues, we're running out of time, but just take a look at this later about the different vaccines that are out to protect severe RSV, because certainly, vaccinating younger children or, having a good vaccine for younger children and pregnant patients will also impact, our community as a whole. So sort of to summarize, can we give flu, COVID, and RSV vaccines together? Well, for one, can be increased minor side effects from vaccination. So it can just make you feel bad, right? If you're getting COVID, flu, and RSV together, and, patients might be like, I'm never doing that again. There are, I think, serious adverse reaction concerns. I don't think that they were very, very rare, but potentially real. I think there's an inability to differentiate vaccine side effects for future analysis. So if everybody gets them all together, then, and we do see more cases of Guillain-Barré or ADEM, what do we attribute that to? And then there was some concern about decreased immunogenicity in older adults. So if you give 2 vaccines together, your body's working to, develop immunity that, are they kind of working against each other, and you don't really get that same immune response. And if you go to the next slide, which is a kind of a challenging slide to read, but this is from the GSK, and it essentially what they looked at was giving the vaccine. So the ratio here is giving it alone overneath co-administration, and you sort of want to have it closer to 1. And for the most part, they did, except for the H3N1 up here, the one that starred, it went a little bit out of the confidence bounds. So maybe slightly in 1 when you co-administered with the H3N1 there may be slightly decreased immunogenicity. However, that's, the clinical impact of that is really unknown. Okay, so in conclusion, I think ACIP recommends shared decision-making in adults age 60 years and older for giving the RSV vaccine. They comment that it's acceptable to co-administer with influenza, and just to highlight that the Canadian guidelines are much more cautious, highlighting that you should wait at least 2 weeks between vaccines if possible, unless again there's circumstances that would make you want to give them more closer together or actually together. There really does, I think, need to be continuing monitoring for safety for those rare but real side effects. And again, we have no data on co-administration with COVID vaccines. Okay, now I'm just going to briefly talk about, I know we're running out of time, like 3 minutes, so I'll be quick, but I want to just quick talk about RSV in nursing homes because this is kind of what we're doing. So we did begin trying to collect RSV data collection for RSV cases in nursing homes. So for those of you who work in nursing homes probably know right now CMS requires nursing facilities to document or to report all positive COVID-19 cases for staff and residents, including things about those positive cases and whether those residents are up to date on their vaccinations, whether they had a hospitalization or whether they died. 2 weeks ago, we added an optional component to also look at RSV and influenza positive tests with similar other questions, including up-to-date status on influenza and RSV vaccines, hospitalizations, and death. So it's sort of a way to just better understand the epidemiology and burden for RSV in nursing homes, and to be able to allow us to do better vaccine efficacy studies in the future. I don't have to go over this too much, but this just is kind of like a sample data collection tool. It's not actually what the user interface looks like, so we can kind of skip through this. And then just here, I'll highlight that in addition to checking or monitoring influenza and RSV cases in nursing homes, we're also collecting sort of vaccinations for all residents as well. This is also optional. And I just sort of reiterate all of this because this is what I feel like is so important to me, is, the reason to do this. And I think some of this gets lost in translation when nursing homes are actually the ones putting it in and doing it. But it can be really helpful to identify outbreaks. It gives us data for quality improvement programs and initiatives, can improve infection prevention and control efforts, helps describe the epidemiology of disease across long-term care, vaccine effectiveness, antibiotic stewardship efforts, and all of the data that's provided can go to local and state health departments, which can then reach out to facilities when needed. And then my conclusion, again, RSV disease causes significant morbidity and mortality in older people, especially those with underlying medical conditions. Testing for RSV can help minimize unnecessary testing and treatment and help with prevention and public health efforts. And then RSV vaccination is now approved and available for adults age 60 and older. Acceptable, as I mentioned, to co-administer with flu and vaccine, but I would maybe consider separating for 2 weeks in those that you can. And that's it. Thank you so much.
So thank you so much. I loved hearing the talk because we've had so many conversations about RSV. I'll open it up to anyone who wants to say hi or has questions about RSV. I see Dr. Bradley waving wildly because we all miss you here. So any questions?
I had a question. So when they said not to give it in anybody that's had a severe or life-threatening allergy, which is kind of vague, I mean, that could be a lot of patients. Can you elaborate on that recommendation a bit?
I mean, no, not really. I mean, I think that, I think it's really kind of what exactly it sounds like. And, I would say that for the most part, there are very, 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 very rare instances of people that have had, severe allergies to vaccination. And so I think, trying to better understand exactly what that reaction was probably would, get you out of that category. I think some people are, overly indexed to, or maybe think that because they, felt terrible after having the vaccine, that was a severe reaction. So that's all the additional sort of context I have around that. I think it's also, they kind of have to put that too. Like if you have a severe reaction, it doesn't make sense to give it again. So.
Okay, and we're at the end of the hour. So thank you so much, Dr. Rowe, for giving this talk. I appreciate so much all the effort that you had to go through. So I am always in awe. I will always be in your fan club. Everyone's cheering for you here at Northwestern.
Thank you all so much.
Yay. So thank you very much. And have a good weekend. Have a good afternoon, you guys.
Bye, everyone.
Great to see you, Theresa.